guys ready? All right, good afternoon, everyone. Welcome to our session, our late-breaking session, Monkeypox, a situational update. My name is Crystal Heischman. I'm the chair of the 2022 Annual Conference Committee, and I'll be your moderator this session. Also co-moderating is our vice chair, Dr. Robin Livingston. She'll be running the online moderator program. Our speakers today are Dr. Alexander Isakov. He is a professor of emergency medicine in the director section of pre-hospital and disaster medicine. He said to keep his bio short. It's very long. And then we also have Jill Holdsworth. She's the manager of infection prevention at Emory University Hospital Midtown. Interesting, Jill is also, or has been, an EMT and certified in sterile processing through ISHM. And without further ado, Jill and Dr. Isakov.
Thanks for the warm introduction. Thanks all for being here. Let me see what I can do about getting slides up. There they are. All right. So I'm Alex Isakov. Again, thanks for the intro. I'm an emergency medicine and EMS physician at Emory University. I've been there for about 22 years. You might wonder, like, why in the world is an emergency medicine and EMS physician talking about emerging infections or infection prevention and control? I mean, the very short story is I took an interest in this when I was getting my Master of Public Health degree in the late 90s, when H5N1 was kind of the new thing. And then when I came to Emory, I had the opportunity to work with the Infectious Disease Division. They were developing their Serious Communicable Diseases Unit, which later came to be a federally designated Regional Special Pathogens Treatment Center. And I was a young faculty member in the Department of Emergency Medicine with a specialty in Emergency Medical Services, or EMS. They came and said, listen, our unit isn't any good unless we have a way to get patients here. And so we developed a comprehensive program. I know you're here to hear about a monkeypox situational update. I'm going to get to that in a second. But that introduction was important because it also explains why Jill and I are on the podium here together today, and again later this afternoon for a second session. I think we firmly believe there should be a strong relationship between the infection prevention community and the EMS community, and hopefully you all will agree too after this session and the session this afternoon. And with that, let me get to monkeypox situational update. We have no conflicts to disclose. I've heard in some circles that means that we have failed to progress professionally, but we have no conflicts to disclose, so it's good to know. And you've heard who we are. I've already taken a lot of heat for my photo there. I need to get something a little more warm and friendly, and we'll work on that. So, monkeypox. Why in the world are we talking about monkeypox? I mean, this has been, largely a footnote in the story of infection prevention in the United States. But the reason we're talking about it is in part defined by this, very short chronology. I mean, just a little over a month ago, on May 7th, a person infected with monkeypox was identified in London after travel to Nigeria. Now, that's not that remarkable or unusual. As we'll talk about later, monkeypox is endemic in Nigeria. People that travel there and become exposed to someone who's ill with monkeypox or an infected rodent can often get sick, and during the incubation period, they travel home and they're discovered to have monkeypox when they get home. So that's not too unusual. 1 week later, 2 additional cases were identified in London, but there was no link to the May 7th case. And further, there was no travel that could be identified to an endemic area. So one of these things that make you say, Then a few days later, we have a case confirmed in the United States. The first case reported by the Massachusetts Department of Public Health on May 19th in a person who had traveled to Canada and returned to the U.S. Also makes you say, and then a couple days later, we see a number of cases, quick succession of cases being reported in mostly European countries, but really now on every continent, to show this global outbreak map, which was just cut from the CDC website yesterday, showing over 1,600 cases of monkeypox in countries all over the world, including over 60 cases here in the United States. So what does that mean for us in EMS and infection prevention, or in healthcare and infection prevention? today, that means that it is much more likely today than it was in April to encounter a patient that could be infected with monkeypox virus. And so we need to be more familiar with the infection prevention measures necessary to control that virus, care for patients safely, provide for the safety of healthcare personnel and the general public. So monkeypox is an orthopox virus. It's a cousin, a distant cousin of smallpox and vaccinia and cowpox. The good news about smallpox, which has been eradicated since 1980, is with monkeypox, it's much less virulent, makes you much less ill than the smallpox virus that we saw circulating before 1980. Monkeypox is endemic in Central and West Africa, so think Nigeria or Democratic Republic of Congo, for example. It has a funny name, monkeypox. Monkeys are not actually the host animal. It's some rodent. They haven't absolutely been able to identify which one, but some rodent, which is the natural kind of host animal. And then when humans or other mammals come in contact with the infected feces or urine of that infected animal, or somehow otherwise get exposed, or come in contact with somebody who's become infected with monkeypox, you get human-to-human transmission. The first human case reported in 1970. And prior to this year, and this year is really unusual as it relates to monkeypox transmission. Prior to this year, there were 6 occasions for exports of people infected with monkeypox to other parts of the world. In 2003, kind of a remarkable case in the US, 2003, 47 cases of human monkeypox, but no human-to-human transmission. All acquired from their pet prairie dogs, as it turns out, who had been infected in some shipment from Africa, and then the loving pet owners got infected with monkeypox. And that outbreak was contained well by the Public Health Authority through use of vaccine, ring vaccination, contact tracing. But 47 cases in 2003. Otherwise, you can see there are sporadic cases that will periodically be identified among travelers who have gone to endemic regions of the world. And in fact, for those of you who maybe didn't pick it up in the news last year, there were 2 cases. There was a case in the United States last year of someone who had traveled from an endemic area in Africa, came through Atlanta, which is how we came to be aware of it, and then passed through to Texas. And then another person who had traveled identified in Maryland. But again, that was quite typical of travelers to endemic areas becoming infected and then arriving in other parts of the world. What we're seeing today is really not typical. So when we talk about any pathogen, at least in the clinical community, talking with people that are frontline healthcare providers, which includes the EMS personnel responding to calls in the field, we try to describe these illnesses in this paradigm that we kind of coined, I-cubed, or identify, isolate, and inform. That it's important for frontline healthcare providers to identify somebody who may pose a risk of having a high consequence infectious disease. Once that risk is identified, what steps are needed to isolate that person to prevent others from getting exposed and ill, and then who is it necessary to inform. So identify, isolate, and inform, and I'm just going to describe monkeypox in that paradigm. So in terms of identifying it, typically it is a part of a patient history that includes signs and symptoms consistent with monkeypox, and then travel to an endemic area. So now we've talked a bit about the travel history. At this point, travel to an endemic area isn't really required. You can have travel to other countries where monkeypox cases have been reported, and there are a number to choose from. Some countries more affected than others. I think the UK actually has the greatest number of cases reported today. So contact with somebody, travel history to a place that's had monkeypox cases, and then contact with somebody who's having monkeypox. If you are in contact with somebody's infectious bodily fluids, as you kind of know, there's an incubation period. And for monkeypox, it's 7 to 14 days, typically, although it can range all the way out to 3 weeks or 21 days. And the typical presentation is a prodrome of viremia, myalgias, headache, fatigue, and lymphadenopathy. And actually, the lymphadenopathy distinguishes it from smallpox. Again, don't need to worry about smallpox. It's only in biosafety level 4 labs. It's not out in the community anymore. But that lymphadenopathy is somewhat pathognomonic, together with the telltale rash, which comes within 1 to 3 days of the prodrome development. And you can see the pictures on this slide are more typical presentation of a monkeypox rash that starts as a macule, becomes a papule, and then a fluid-filled vesicle and pustule, umbilicated, distinguished from chickenpox because all the lesions look roughly the same age, as opposed to chickenpox where you get one crop that kind of starts to age and then you get another crop of vesicles. So that's the way to distinguish it from chickenpox. But you get what's called a centrifugal rash, so typically more affecting the face and the arms and the legs as opposed to the torso, although you get it all over. And it lasts for about 2 to 4 weeks. And we'll mention this again, but you're infectious until the last scab falls off your body. The monkeypox cases that we're seeing now are a little bit atypical in presentation. And you've probably heard this. The rashes are presenting as genital rashes, as perianal rashes. Patients have fever, swollen lymph nodes, maybe painful swallowing if there's oropharyngeal involvement. But fever isn't an absolute requisite, so some patients have presented with rash and no fever. And those swollen lymph nodes, while we talk about lymphadenopathy and the swollen lymph nodes as maybe a general presentation, submandibular, subaxillary, inguinal. In this case, because in some cases the rash is very local. Again, like we say on the slide, perianal, groin, thighs. Sometimes the lymphadenopathy is local too, like for example, just inguinal lymphadenopathy. And so it's a little bit of an atypical presentation, something to be aware of. And it's in part because the community that is being disproportionately affected, at least as this is being reported in non-endemic areas today, is in the community of men having sex with men. And so it just happens that that's part of the epidemiology today that increases maybe or gives you some pause to think that if you have an sort of diagnosed rash and some malaise and some other prodrome in that community, you might think, oh, well, have you traveled somewhere and could this be monkeypox? The CDC and others have cautioned that especially local rash in the groin area can maybe be mistaken for other sexually transmitted infections, like herpes, for example, or chancroid, or secondary syphilis. And so all of this is to increase our awareness. The MSM community is not the only ones at risk. Everyone's at risk. If you come in contact with somebody that's infected, have close contact with them, get exposed to the fluid in those vesicles or their respiratory secretions. Anyone can contract the virus, but the epidemiology of it today makes us be more concerned in that MSM community. And as I think we've mentioned already, where typically we would say, well, if you haven't traveled to an endemic country, the likelihood of you having monkeypox is like nil. But today that's not true. As we've seen, there's over 1,600 reported cases globally. That number is certain to rise because we have increased awareness of the disease and increased reporting of the disease. With regards to isolate, so maybe now we've shared enough to identify somebody with monkeypox. Well, once you identify somebody at risk for monkeypox, you want to isolate them, protect others from having an unprotected exposure. This community is very familiar with that. And why would you want to do that? Well, one, to prevent transmission of the illness, and two, because it can make you sick. There are two clades or two generally regarded or recognized strains. A Central African clade that has a case fatality rate of up to 10%. And then the West African clade with case fatalities reported as high as 1%. So the virulence of the two strains is quite different. From the cases that are being reported in this outbreak, those that have been typed as West African clade, which is good news because it's less virulent. It's also harder to transmit from person to person. And some of the epidemiology is bearing out the virulence of the virus in that no deaths have been reported in non-endemic countries since this outbreak. How do you transmit it from person to person? Well, through contact with infectious bodily fluids. So as you develop the rash, you have fluid-filled vesicles, sometimes first clear, then what looks like purulent fluid. Contact with that fluid in a break in your skin or in your mucous membranes or any compromised skin will put you at risk for exposure to the virus, after which then, after an incubation period, you develop signs and symptoms of illness. Also, respiratory secretions are teeming with the virus. So, secretions from your nose, oropharynx, if I cough, sneeze, rub my nose, touch something else, that's another risk for infection. There's also risk for contaminated linens and contaminated waste, and there's documented transmission of monkeypox through exposure to contaminated linens. And so those are all important transmission vectors. You see there's a note here for some risk of transmission via suspended droplet nuclei. Now, we may not have enough time to go through all the debate that we might have around infectious aerosols associated with monkeypox. And this is being debated in scientific assemblies as well as in the media. I think the CDC's guidance around use of an N95 respirator, NIOSH approved and fit tested, is important because there are conditions under which suspended droplet nuclei or aerosols are more likely to occur, like when you're performing an aerosol generating procedure, for example. Intubation, suctioning, CPR, endotracheal intubation, bag valve mask, or non-invasive ventilatory support like CPAP or BiPAP. These things all generate, suspended droplet nuclei or aerosols, which would put you at greater risk of transmission, even with monkeypox, which is why I think in an abundance of caution, that recommendation is being made. But the vast majority of cases are through close contact, exposure to the fluid in the vesicles, exposure to the infected respiratory secretions that you can share either with direct contact or through heavy droplet. But it doesn't make the risk of transmission via suspended droplet nuclei zero. And again, mentioning as I did before, that you're infectious until you get a crusting of lesions. PPE recommendations. Standard precautions, plus gown, plus a fit-tested, NIOSH-approved N95 respirator, and eye protection. So in the EMS community, but we've adopted this from your science of infection prevention in healthcare, we also try to adopt a hierarchy of controls. And our partnership here is, between the EMS professional, which is me. I work in the emergency department too, so I feel anchored in the hospital as well, to my colleague, Jill, who is an infection preventionist at Emory University Hospital, Midtown, which you all know. So I'm going to give a bit about the hierarchy of controls in that pre-hospital environment before transitioning the patient to the care of the hospital, and then we'll have Jill handle the presentation from there. But first, and you guys are very familiar with this, of course, source control. Put a mask on the patient if they can tolerate it to prevent transmission of heavy droplets, which under these hot lights you can see I'm generating. You guys should be very grateful, that you're probably a good 20 feet, from me. But source control is important. Also, if someone has visible rash, weeping wounds, try to apply a barrier sheet to prevent exposure of the EMS or other healthcare personnel who are having to make patient contact. Ensure that all healthcare personnel, other personnel are in appropriate personal protective equipment. Gown, glove, N95 respirator, face shield, goggles. Limit the number of personnel making contact. For EMS, we've always made it a note to say, if you can separate that front of the ambulance where somebody's driving it from the patient compartment, where the patient might need an aerosol generating procedure that could generate suspended droplet nuclei, it's best to separate that driver compartment from the patient compartment. And be cautious with aerosol generating procedures. If you need to perform one because the patient needs it, then by all means do it. But if that's the case, then you need to do what you can to modulate air exchange in the back of an ambulance, and also be sure that you're wearing your NIOSH-approved fit-tested N95 respirator or better when managing that patient. In the ambulance, it's very unlike a controlled, engineered airborne infection isolation room in a hospital where you're getting pretty certain laminar flow, maybe in the 12 air exchanges per hour. There's some limited studies about getting actually high numbers of air exchanges per hour in the back of an ambulance by turning on an exhaust fan and increasing flow of air into that space and ensuring that your controls don't allow for recirculation of air. NIOSH actually helped us with a study back in, I think, the early 90s, but we need to replicate that with the modern ambulance fleet and see if we're still able to do it. Of course, for the EMS community and for others that have to clean their own equipment, you need an EPA-registered hospital-grade disinfectant. Monkeypox is an enveloped virus, so it's actually fairly easy to kill if you're using an appropriate disinfectant, which is good news. So wiping down with an EPA-registered disinfectant all surfaces that potentially contaminated with infectious bodily fluids key. Jill may go into this more, but waste management is actually another significant consideration. Category A waste is highly regulated waste. When we talked about management of patients with Ebola virus disease, for example, in 2014, 2015, 2016, the waste generated in caring for those patients was considered Category A waste, highly regulated. Waste management companies that were going to manage that waste and transport it for ultimate disposition needed special licenses for that. If you have a patient that you're caring for with monkeypox that is infected with the Central African clade of monkeypox, that's the one that's more virulent with case fatality rates up to 10%, that's actually considered Category A waste. For West African clade, which is mostly what's been identified so far in the non-endemic areas in this outbreak, that waste can be managed as Category B waste, which is normal medical stream waste. The challenge, of course, is you don't know what strain you're managing when you're managing the patient. And so this is a question that you and your health system or your operational partners have to decide. How are you going to manage that waste until you have an identification of what clade or strain monkeypox the patient's infected with. And then another measure to help prevent transmission in the community or among co-workers is monitoring healthcare personnel and others that have exposure to potentially contaminated waste or to infectious bodily fluids, monitor their health for signs and symptoms of illness for the duration of an incubation period, which is 21 days. Identify, isolate, and then inform. Well, who would you want to tell that you have somebody that you suspect is infected with monkeypox? Well, if you're in the EMS community, you want to let other responders know. Jill knows this because she's an EMT. She's responded in the field. I'm an EMS medical director. I know what things look like. You've seen it, in the community or on TV. Like, there's never just one or two people that show up to a 911 call. There's always a whole team of people, the fire-based first responders, another company that's responding with the ambulance, and others. And so you want to let other responders know, hey, we suspect this person has monkeypox based on the history and physical, and so don't make patient contact unless you need to, and if you do, you need to be in the appropriate PPE, and implement the appropriate infection prevention measures. Let your supervisory personnel know that you might be on scene a little longer than your typical patient with flu-like symptoms. And then if, and this almost is always the case in EMS, if you're going to transport that patient to your local emergency department, give them as much lead time as you possibly can to say, hey, we're coming to you with a patient with XYZ, and based on the history and physical, we think this person might have monkeypox. The receiving facility wants to know, and the more time they have to prepare to get the right room available, to have a team that has the appropriate PPE on board, and to make other preparations, the more time they have for that, the better. And of course, somebody should inform the public health authority, whether that's the EMS community or the hospital-based community. It's less important than being sure that somebody does it. My last slide is just talking a bit about medical countermeasures or medical therapy. And I think this is important to just touch on, because if you are in the business of interacting with patients, if you're in the business or in environmental services, waste management, any place where you might come in contact with infectious bodily fluids from a person who is infected with monkeypox, you want to know that if you have an inadvertent exposure, that you're going to be cared for, and that there are ways to care for you. So the first, sense of reassurance you should have with Western African clade monkeypox, not that I want to contract an illness that has a more case fatality rate of up to 1%, but that's certainly better than 10% and 30%. Two, most of all of the cases, actually, as we mentioned before, that have been reported have been self-limiting, and there have been no deaths associated with this particular outbreak. Supportive care is primary. Your body will eventually clear the virus, so supportive care is important. Now, there are antiviral treatments available. You would typically have to talk to your local or state public health authority to gain access to those antivirals. They're stored in some quantity in the Strategic National Stockpile, and they're reserved largely for patients that are having serious consequences of infection. So need for hospitalization, or worse, having a monkeypox and pneumonitis or encephalitis. Those patients that have severe illness or at risk for having severe illness can benefit from antiviral therapy that's really was approved for smallpox treatment, but is showing some effectiveness at treating monkeypox as well, largely in animal studies. And vaccine is also available for post-exposure prophylaxis as well as pre-exposure prophylaxis, again, depending on your status. So Imvanex, you might have heard, the U.S. government is trying to acquire more and more doses of Imvanex. There is some in the Strategic National Stockpile. They're acquiring more from the manufacturer. And this is a vaccine, actually, that was FDA approved and licensed for preventing smallpox infection and for preventing monkeypox infection. It's about 85% effective at preventing monkeypox infection, really designed for smallpox prevention. What's good about Imvanex, and that's a fairly new drug, was FDA approved in 2019, is that unlike ACAM 2000 or Dryvax, which if anyone in this room was vaccinated, prior to 2000, got Dryvax, ACAM 2000 or Dryvax has live vaccinia in it. You get the bifurcated needle and 15 jabs in your arm, and you get a vaccinia lesion. Protects you from smallpox, but there's some more significant side effects associated with that live vaccinia vaccine, as opposed to the Imvanex, which is a non-replicating virus in humans. So it comes from it's created in the lab, but monkey strain of vaccinia that doesn't replicate in human cells. So patients that are immunocompromised or have atopic dermatitis or something else will tolerate it much better. And these vaccines are valuable not just in pre-exposure prophylaxis, and the people who get pre-exposure prophylaxis are typically groups, let's say, are working in the field in endemic countries managing patients with monkeypox, or laboratorians who are charged with processing monkeypox samples. Post-exposure prophylaxis is appropriate for anyone who's had close contact or high-risk close contact with somebody that has monkeypox. And even 4 days post-exposure can prevent disease, and has value even 14 days post-exposure prior to development of signs and symptoms in having you have a less severe case of monkeypox if you were to contract it. So that's just a couple minutes on medical countermeasures and medical therapy as it relates to monkeypox. But with that, I'm going to turn it over to my colleague, because in the EMS world, I've done my job. I've carefully transferred the care of the patient to my colleagues in the hospital. And Jill, now it's all yours.
All right, thank you. Thanks for coming, everybody. This is so great. I know this was a last-minute session, but I'm happy to sort of see all of y'all out there. And what I want to do with the rest of this presentation is to really talk about what do you need to do when you go back to your facility? What kind of questions do you need to be asking if you don't already have a very well laid out plan? And what do you need to start thinking about if you haven't already started thinking about this? So whenever I do presentations, I always like to think that you've left here with some sort of question to ask or thing to look at. You've written down something that you're thinking, I'm going to go and I'm going to think about this and I'm going to go do this when I get back. So hopefully you leave this session with a better understanding of monkeypox, and you leave with, I'm going to go back and I'm going to think about doing this, asking questions to the lab or to the ED or to whoever you need to go ask these questions to. So before I start, just a little bit of background about myself. Why do I care so much about all of this? I love emergency management. I obviously love EMS enough to go become an EMT after I became an IP. So I know Crystal told you all that, and you're probably thinking, how did she have time to do all that? And the answer is easy. I did it at night because we have no free time, right? So I would have told you I did it in my free time, but I don't have any, so I did it at nighttime. So it was great practice for all of the calls and pages we got during COVID, where we never slept for 2 years. So it's great practice for all of that. So that being said, it is really important that we have a great relationship with EMS, and that's what we talk about in our session the next hour is how do you form that relationship with EMS, and how do you just get started? If you already have a relationship with your EMS, then what's your next step? So because we have a great relationship already with our EMS group, we've been able to be really successful when things like this come up, and when COVID started, and now when monkeypox has started, we've already had a great kind of baseline to move forward from. If you don't have that already, then that's where you need to start. If you already have that, then you've kind of got a springboard to go from. So let's talk about patient placement first. So like Alex mentioned, they've kind of did their part, they've assessed the patient, but we have different ways the patients come into our facilities, right? Whether you're outpatient, whether you're an inpatient place, whether you're EDs, let's talk about how these patients come into our facilities. So we've been thinking through all of the different ways that these patients might come into our facilities. Some of them are gonna walk in, some of them might come in by ambulance. So you've got to start thinking about all of the different modes of entry and how you're going to deal with those modes of entry. Do you have your registration folks ready to ask the right questions? And do you have them ready to take action from there? And where are you going to put those patients once you identify them as a high-risk patient? So that's kind of step one. That's one way the patient might come in. If you're an outpatient facility, again, is registration asking the right questions, and do you know what's going to happen as soon as that patient is identified as a high-risk patient? What's going to happen to them from there? So that's that identify part. Identify them early and then isolate them early. But if you're not prepared for that, everybody is going to panic and not know what to do with the patient, and so you have to figure out that first step. If they come in by ambulance, then there's a chance they've already been identified as a high-risk patient. There's a chance they may not have. So let's hope that the ambulance folks have already said this is a high-risk patient. And one thing that we found out, this is just a great example, we were trying to work through this process as well, and we found out that we did have a dedicated EMS phone line, which is great, but nobody actually was carrying the phone. So, and I actually had said to Alex last night, I refuse to give you the phone line yet because I want to make sure everybody has the phone before we distribute that number. So that's a great thing to find out. Who are they going to call when they come in? Because you don't want them to just waltz right in with the patient on the stretcher. You want to know how are they going to notify you, and are they going to hold the patient in the bay until you're ready for them? What is your plan? And that's the plan that we have had since we've been planning for Ebola. They're going to hold the patient out in the bay, they're going to call us, and we're going to wait until we're ready to bring them in. But if you don't have that plan, it's going to be utter chaos. So those are just things that you need to think about. And then what room are you going to put them in? Do you have a designated room, or are you going to be figuring that out when they get there, which is not what I would recommend. But you want to figure out what is that room, what is the path that you're going to bring them to, which is really important, whether they come from the lobby, whether they come from the ambulance bay, and work out that path that they're going to be brought to, and practice that. We practice it all the time so that we know how we're going to go through that route, how we're going to, do we need to block off the hall? Do we need to make sure that we're going a different route if there's construction? So work all of those things out in your facility so you know exactly where you're going, what route you're taking, do you need security there, and have all that ready so that when it happens, everybody's very calm, because you know it's going to happen in the middle of the night on a holiday when no one's around. And when it does happen like that, everybody's calm, collected, and you don't have to worry about anything. All right, so we kind of touched on isolation precautions a little bit, and I purposefully included 2 boxes here because there's, and I'm going to show you in just a second, the WHO document that came out on Friday. But that's the bottom box there. The top box is from NETEC.org, and if you don't know about the NETEC resources, I highly encourage you to write that down, NETEC.org, and go to NETEC and get their resources. But NETEC has a ton of resources on infectious disease, communicable diseases, but this is a great box on the top there, just about general transmission-based precautions with monkeypox. There's a great Back to Basics PPE and monkeypox podcast that you can listen to, and just looking at what should we be doing. So again, this goes back to what kind of room you're putting them into. Do you have that airborne room that you're going to use? Is that going to be your process? If you don't have one, where are you going to put them? And do you have that single patient room that you have ready to go, that you've designated? So make sure you have that plan ready to go. And if it's not an airborne room, what's it going to be? And is it the safest option? Do you know what PPE you're going to use? Is everybody trained to use that PPE and comfortable? And is everybody fit tested, like Alex mentioned? And all of that is really important. We really focused on that at the beginning of COVID, and I think we need to make sure we focused on it again. So just kind of going back to those basic things and making sure that our team is ready, our team is calm, and if they are, then all of this is going to go very smooth. Also, looking at some of the CDC websites for just standard precautions is a great reminder. You can send it out to all of your staff. And also making sure the patient has on the mask. I know that we probably haven't dropped the mask mandates for patients coming into the ED waiting rooms, but that's something that we've gone back to really emphasizing in our ED waiting rooms, making sure that somebody gets physically handed a mask when they come in, and that's really important too. So anybody that comes in, not just anybody that's high risk for monkeypox, anybody that comes in, if they're not wearing a mask, they need to be physically handed a mask. And we're very lucky at our facility. We have public safety there all the time, and they have actually been the person who's been just kind of watching over all of the waiting room to make sure people keep their masks on. So if you have somebody like that can kind of keep an eye on the waiting room, that's a great option to make sure that everybody in the waiting room keeps their masks on at all times, not just people that are high risk, just everybody. So making sure that the patient keeps a mask on, no matter who they are, but especially those monkeypox high-risk patients, making sure that they keep a mask on as well. And then I put the WHO box down here because the WHO mentions in their document that came out Friday this reference to varicella a lot in their document. And they are probably doing this because a lot of these patients are coming in with lesions that look very similar to varicella. So just mentioning it a lot because they want to make sure that you're also considering that, because they want you to be thinking about, oh, does this person need airborne because of the potential for varicella? So you do need to have that in your mind, that even though some of the guidelines say airborne isn't required but recommended, you do need to be considering that. And if it's in the differential, you need to make sure that you have that room available. And this is just a picture and an excerpt from the WHO document that came out on Friday. You can get it. It's out there on the web. So it's a very long document, but it's got some good information in it. So you can go out there and find it fairly easily. And I know these slides are probably not in the app. I see some of you all taking pictures of them. We're happy to send them to you. So there's going to be a QR code at the end. You can send us your information. I'm happy to email these to you guys. And talking about linen handling, I copied this sentence at the top right from the CDC website because I think it's really important. So it says soiled linen should not be shaken or otherwise handled in a manner that may disperse infectious materials. And I think this is important because have any of you ever been to your commercial linen facilities where you ship all the linen to, and the factories? Have any of you visited those factories before? It's hard to see, so. Okay, I hear you saying yes. I can't see you saying yes. So I'll trust that you have. Okay, so if you have, you know that they don't handle linen with care once they get it there, right? They dump it out. It gets thrown out on the conveyor belts. They do shake it because they know that we accidentally put the wrong things in the linen sometimes, and they have to shake out the sharps and the things that we leave in there for them sometimes. So even though this is absolutely the right statement to make, we cannot confirm that that's not going to happen at those factories that do all of the linen in bulk. So that's something to consider if that is what your linen process is. You can't confirm that that's not going to happen when you send your linen off to these big warehouses to be processed. If you do your linen on site, that may be something that you can do a risk assessment on, because it may be a totally different process for you that you can mitigate in-house. But if you're sending your linen off, then you should consider doing your soiled linen like all of the other waste that you're handling, because there's just no way to confirm that you're not going to be able to keep your linen without being shaken. So process questions to consider when you go back home. What are you going to do with the linen that has direct contact versus the linen that's stored in the room? So this is something that we've been considering. If we're going to have a patient in a room, can we just take out all of the extra stuff in the room? So you know that our rooms have lots of extra things in them, but when you have a patient like this in a room, can we just get all the extra stuff out of there before we put them in it, so we don't have to have that question of just throwing everything away like the category A or category B waste? Can we just get all the extra stuff out of there, including the linen, including all the extra supplies? So consider that as part of the room prep What can you get out of there that you may not need? Because you may need to keep some things in there, but do you need to keep all of the extra linen? And then remove all the linen and supplies. And then considering how you send your linen off is going to help you understand how you treat that linen when it comes in contact with the patient. And you're probably going to need to treat it like any other waste. And then just some things to consider with the lab. I'm not going into everything that you need to consider with the lab because that's not really in our purview, but some of the things that you really need to have conversations about when you're talking about labs, lab transport. You need to think about transporting the lab tubes, about walking them to the lab, not using the tube station, about double bagging and the type of bag to use. And I say the type of bag because we have the solid red bags and we have the clear bags. What we decided that we're going to use is a clear bag so that you can see what type of tests are inside the bag. I know sometimes they like to use the solid red bags because it's very clearly biohazard, but what we decided was the clear bag so you can see what is actually in it, but double bagging it. There's also lab risk assessments that you can do with your lab to make sure that the right PPE is being used and to assess what core labs can be done on site versus somewhere else. Are you safe doing what you're doing on site for just regular routine labs? So I would talk to your lab about the comfort level of just doing regular CBCs on site for some of these patients. And do you have everything that you need to do those types of labs and sequestering the waste? And do you know what your process is going to be if you would have to test a patient and transport it to the state lab? What would you do? Do you have a courier? Do you know how to get to that courier and get them there? How would you need to package it, which is my next point? Do you know who those certified packers are? Do you have enough? Is there somebody on every shift for category A and category B? Do some people need retraining? Is everybody comfortable? And those are some of the questions that are going to go through everybody's mind. And when I worked at a smaller hospital, we had one person who was a category A packer in the lab, and they were at one of those folks that were, I'm an 8-hour shift person, and if it's outside of my 8-hour shift, I am not coming back to do it. I don't care if you have Ebola, I am not coming back. And so I ended up being the other alternative person who was trained, and it was understood I would come back in the middle of the night to package up if we ended up having an Ebola person come in, which thankfully we never did. We were a small town place, but that it's an important thing to make sure that you have enough people on every shift to package these specimens if you would have to. So make sure it's category A and category B packers, depending on what type of specimens that you're sending, and making sure that you know your process if you would have to send it to the state health department. And the waste handling has been a big topic, like Alex mentioned. Anything that has been determined to be West African clade is considered category B, which is just like our normal isolation waste, but that's after it is categorized as West African clade. So this is something that you really need to work closely with your local health department on. And so if you don't know who that person is, or if you haven't talked to them about this yet, go ahead and talk to them and say, hey, have we discussed what the waste is going to be, or have we discussed what we're going to do with the waste? And go ahead and have that conversation about what happens if we have something that's category A. What are we going to do with it? Because you don't want to get in a situation where you have to know what you're going to do with your category A waste and you have no idea. If you have a waste management company that would be taking this kind of waste out of your facility, have that conversation now with EVS and see what your process would be. Don't wait until you need to have it. Have it now so you have a plan. And then once you need it, which hopefully you never do, then it's going to be so much easier. And one thing we did is we live in Metro Atlanta. We have a couple different counties. We went ahead and talked to the neighboring counties too. So if we had to actually transport our waste, then we know that we have our act together here in our county, and we've already had the conversation that we may have to transfer it over to the next county over should we need to. And so we've already had those conversations about a cross-county transfer if we had to ever do that. So I would go ahead and start thinking about this. The waste can be really stressful. Your EVS director would need to work with you to figure out what you would need to do, how to get the waste out of the room, where you might store it. It's very specific regulations with where you store this type of waste when you're kind of waiting on that answer of is it the West African clade or not? Because when you don't know, you need to store it like it's category A, or it might be category A until you know. And so that's what you guys need to understand what that process is going to be for you and your facility. And then looking at some of these other things, we've kind of already talked about most of those, and they're pretty standard things about linens, disposable instruments, and things going back to sterile processing. And this is just a chart about the occupational exposures. If you haven't seen this yet, this is the chart that they're using about high, medium, low, and no risk. So this is just showing you what they're basing the kind of low risk category off of for that 21-day monitoring period of symptoms after you've treated a patient with a confirmed case of monkeypox. So if you haven't seen this, it's good to go ahead and take a look at it. That way, if you do end up having a confirmed case, you kind of know what the categories are. And basically, that low-risk category is kind of everybody fits into that one. If you treated the patient, then you fit into that monitoring period right now. And this is just an example, a snippet out of our debrief process. And I wanted to show this because I think this is something that we do really well whenever we have events. We started doing this in the beginning of COVID, and we kind of laugh at it now because we did it for the first 3 or 4 COVID patients that we had, thinking we can do this for every COVID patient and we're going to learn so much. And then we ended up having, I don't even know how many we ended up having a day, but in the beginning it was one, and then 4 days later another one, and then we were doing them all, and we would never have kept up with it. But we did learn a lot when we did them. But if you don't have a hospital debrief process when you have PUI type events or emergency management type events, then you definitely should get an after action type report where you can debrief and you include every department that could potentially be involved. We include safety, we include lab, we include respiratory, radiology, public safety. We include everybody that it could potentially be involved in the ED, and we learned so much from each other, and we keep an action list and an Excel sheet to make sure that we capture every action item that we could possibly need to address, and we just keep working at it. And every time something happens, we just keep adding to it, and some things are more long-term than others. We usually find that communication is one of the biggest issues, communication that an event is happening, and then a kind of a closing out of events that here's the result of what happened in the event. So this is just a box of the summary, but the form is actually many pages long. But we usually try to do it within about 48 hours. We do try to always include our EMS partners. And so that has been really helpful, especially if they transport a patient to us, then we want to make sure that we include them. And that's been really helpful and giving us a lot of insight into what we can do better on the EMS side as well. And I have to, of course, mention that APIC did release a info sheet recently, so make sure that you head out to the APIC website and get their infographic paper to help educate. This can be the community, this can be people in your facility, so make sure that you head out and get that. And I will let Alex do some of the summary.
It's just the laundry list that you see. I think what we know today with as many cases as we've seen globally and more expected, that we just need to be alert to people with an undiagnosed rash, especially if they have a prodrome of some kind of febrile illness. And this paradigm, I think, is useful. Identify, isolate, and inform for frontline healthcare personnel, which includes the EMS community. We got to remember the appropriate PPE, gown, gloves, NIOSH-approved, fit-tested N95 respirator, face shield, and eye protection. Simply, we just need to be protected from exposure to infectious bodily fluids. Do you want to take it from here?
Yep. So we want to keep reiterating private room, private bath, and that's something that the WHO document really reiterates over and over. And if you can't do airborne room, it keeps saying private room, private bath. And so really thinking about where you're going to put that patient. And the airborne infectious isolation room when performing aerosol generating procedures, we didn't quite touch enough on that, but it recommends that you have a private room, and unless you're doing something aerosol generating, then you definitely need the airborne room. And so I really would consider that when you're thinking about what is your protocol going to be, because it's very difficult if the recommendation is airborne unless you're doing something aerosol generating. Do you want to take that that chance of, I might do something aerosol generating and then I'm going to have to quickly move this person over into an airborne room? So consider that if you do have airborne rooms available, if that's going to be your procedure just for safety and simplicity. Laundry and waste management, obviously a lot to work out there, a lot of recommendations, and they'll probably continue changing and updating as with the situation is. So continue looking at updates, continue reading, because these things are going to be ever changing since this situation is very fluid. The health monitoring, I would look at that table that is in this presentation just for awareness, and then when you have to deal with it, then learn a little bit more about it. And then the public health guidance that for the vaccines and the PrEP, that is good to know, and just educate yourself. And of course, that's probably also going to be changing, updating more guidance as well as we move forward. We have lots of resources out here for you. I'm going to leave this here for just a second in case you guys want to capture some of these QR codes for some of these NETEC and CDC resources, and some of these have podcasts attached to them. So we'll kind of leave this here for a second, and then I will move it on to the next slide in a few minutes during the Q&A, which is where our QR code is, where you can contact us and send us your comments and questions. And I think I landed right on the time limit that Krista was giving me so that we can take a few questions. Thank you all for coming, and we're happy to chat. We do have a session right after this, so if we don't get to your question, then please send us a question.
Yeah, you should follow us to the next presentation.
Or just come with us, yes.
All right, thank you, Jill. Thank you, Dr. Eiskopf. Let's give him a round of applause. That was perfect. We are so glad you could join us today for this. We are going to start the question and answer session. We have Stephanie, who will be standing here with the microphone. Wave your hand, Stephanie. So she'll be doing questions here. If you approach Stephanie, please make sure that you announce who you are and where you're from. We also have Dr. Robin Livingston, and she will be doing online questions for you all today.
Hello, I'm Alice Blackman with Baylor Scott & White. I have a question about people who have had the smallpox vaccine years ago. Number one, have any close contacts come down with monkeypox and have had the smallpox vaccine that you know of?
Yeah, in short, if I understood your question correctly, as it relates to having had the smallpox vaccine previously and then coming in contact with monkeypox. So smallpox vaccine does confer protection against monkeypox based on the data that we have available for the currently available vaccines. It's about 85% effective. Actually, there's some consideration that where monkeypox is endemic, where, let's say, in the Democratic Republic of Congo, they get over 1,000 cases in a year, and there are other cases in Central and West Africa yearly. Some thinking is that as the immunity from a smallpox vaccination campaign that largely ended in 1980, as the immunity associated with that vaccination is waning, then protection of the population, in general, from monkeypox is also waning. And then we know that because smallpox was declared eradicated in 1980 by the WHO, and the United States stopped vaccinating against smallpox in 1972, that a large proportion of the U.S. and global community is not vaccinated against smallpox. And if you asked, well, why did they stop? Well, in part because smallpox was no longer circulating. It was eradicated from the wild. And two, the available vaccines, Dryvax, and up until the most recent vaccines have some significant side effects associated with them. So population based numbers would right now steer you away from a population-based vaccine program. Vaccinations now would be on an as-needed basis because of close contact or high-risk close contact with somebody who has monkeypox. But hopefully that answered your question. Smallpox vaccine does confer benefit, and there's maybe even still some benefit among those that were vaccinated, let's say back in the 70s, but that immunity is waning.
Okay. Jill, I'm going to toss a question your way. Have you decided yet for your facility, are you going to allow pregnant healthcare workers to care for patients with confirmed or suspected monkeypox?
That's a loaded question. Right now, I don't believe there's any CDC guidance that says that there are any communicable diseases that pregnant healthcare workers are unable to care for because PPE works. And I think that's the take-home message that we say for any communicable disease, that PPE works. And that's what we say at our facility, and I know that's what a lot of IPs say, that if we follow our PPE guidelines, that we are protected and that PPE works. That doesn't mean that won't change, or that we wouldn't preferentially reassign someone if they so choose to, or have a really strong feeling that they really feel unsafe. And that's something that the unit leadership would choose. That isn't something that IP would get involved in. And I think that's how we all feel. I do not reassign staff members because that's not my job, but we would follow our own policies, which is we follow the PPE guidelines for transmission-based precautions.
Okay, thank you.
Hi, my name is Teresa, and I was wondering, since we're still in this COVID pandemic and hopefully nearing the end, we have a lot of facilities that maybe do not have negative pressure rooms or enough, and there are circumstances where you may need to prioritize monkeypox potential patient versus COVID. I appreciated your presentation. It did acknowledge the potential risk of aerosolization and transmission, but the CDC recommendations seem to be a little bit not quite as direct. And so I'm curious your opinion on whether you would prioritize a monkeypox patient over perhaps a COVID patient that we know can be airborne versus the potential given the levels of immunity that we currently have in communities of COVID.
I mean, I think it's a good question. The question is, I think, really around resource management and how you would prioritize your airborne isolation, airborne infection isolation rooms. I think, clearly transmission of COVID-19 by suspended droplet nuclei or aerosol is well documented. And there's a much greater risk of transmission of COVID by way of suspended droplet nuclei than there is risk of transmission of monkeypox by way of suspended droplet nuclei. That said, if I was performing an aerosol generating procedure on a patient infected with monkeypox, my preference would be to have them in an airborne isolation room. If I really was stuck having to make a decision for, let's say, long-term care of a patient sick with COVID or sick with monkeypox, and I only had one airborne isolation room, I guess based on what I know about transmission of COVID by way of suspended droplet nuclei, I'd put the COVID patient in there. But I would say, care of a patient with, and I'm happy to be corrected, Jill, care of a patient with monkeypox is, the greatest concern for transmission in interacting with that patient is going to be exposure to the fluid in their vesicles, their oropharyngeal secretions, heavy droplet. That's going to be the primary means of transmission. And then, I guess, transmission through fomites, like the linens and otherwise. That's the primary concern with monkeypox. Aerosol generating procedure, it'd be great to have them in an airborne isolation room. At a minimum, they need to be in a private room. And you need to be in the appropriate PPE, as does anybody else making patient contact. Did I get it right?
And I think that's what the guidelines say too. They would like for them to be in airborne rooms when available, but we know that not everybody even has airborne isolation rooms where they are. But yeah, when possible, have them in an airborne room. When you don't have one, keep the door shut.
Hello, I'm Amanda from Children's Wisconsin. Very timely information. Thank you for that. My question has to do with screening of these patients. As you mentioned, there's multiple ways these patients may present to our organization. And talking about the patients who may be walking into an urgent care or an emergency department and they meet the registration staff first, we have screenings that help identify infectious disease as well as our travel screenings. But what questions would you recommend that these individuals ask, knowing that they're not necessarily trained on assessing, but wanting to make sure that we're identifying these patients early so that we can isolate them as early as possible?
A lot of the screening questions are the same as your symptomatic screening questions that you should hopefully still be asking for COVID, and also understanding the history of the patient. So sometimes you may not be truly getting the picture of the high-risk nature of this patient until they are coming, depending on where this person is. They may be in the triage area of the ED before you really get a picture of what this patient is for. You know, sometimes these patients are checking in and they're checking in for something completely different than a rash in travel. So that's where putting the mask on the patient is really important first, to make sure that we're protecting them. But if they check in and they say, I'm here to be seen for this new rash that I got, that would obviously be something to see that patient a little quicker, but instead of sending them back out to the waiting room. But sometimes it's not going to be easily detectable for what they're checking in with. But having those same screening questions that we've been using for a long time are going to be the important ones, because we want to symptom check them. And then once they have those triage questions, making sure that we're assessing if they have had that travel and they have had that history, and getting that complete history is where we're going to catch to see if they have what we're looking for.
Okay. We're going to go back online. Do you know what the R0 is for monkeypox? And can a person have asymptomatic infection?
So actually some asymptomatic infection's been reported. And it's not clear if you can transmit if you're asymptomatic, but there's been some report of asymptomatic disease, which is interesting. I mean, the general convention on transmission, as we mentioned earlier, is that you're contagious when you're symptomatic, right? You're most contagious once you have developed rash, but you can also transmit. Maybe less likely, but it's also possible to transmit during that prodrome phase. Okay. The front end of your question, though.
The R0. If a person has monkeypox, then how many other persons is it estimated they can transfer monkeypox to?
Oh, that's a great question. Honestly, I don't know what the R0 is off the top of my head. Do you know?
I do not know.
Yeah. It's low. Compared to COVID, it's very low.
Okay. Thank you.
Yeah, you're welcome.
All right. Thank you very much to both our speakers.
Thanks so much.
Appreciate it.
All right, we're going to get our presenters off to their regularly scheduled session. If we can put, okay, it's up there. So Jill mentioned that the QR code, if we didn't answer your question today, you can send your question to that QR code and they'll get a hold of you. Once again, thank you, and another round of applause.